Assalamu alaikum. Welcome, students. So today class is dedicated to my teachers on the occasion of Teachers' Day. So these are my professors who are source of inspiration for me. Dr. Shyam Sundar sir, Professor Murthy sir, Professor Ravindranath sir, Professor Risha ma'am, and Professor Timareddy sir. So today class is dedicated to all teachers. So we'll start today's class. So before starting, I just want to remind you, my videos are important because they are very precise and exam oriented, and they are very interesting and simple presentations. So please like, share, and subscribe to my channel. So this is in continuation of previous three classes where we have done with anterior shoulder dislocation, recurrent shoulder dislocation, and also posterior shoulder dislocation. So in continuity with the previous three classes, today is last class of shoulder dislocation. So here is the case of 33-year-old male patient who sustained fall from the tree holding the branch. So this mechanism of injury is very important. He fall from the tree holding the branch with one hand, and when he was holding, whole of his body got fulcrum out through the glenoid. So then he heard a click in the shoulder and he start having pain. And when he came to the emergency, the shoulder was locked in straight position. So it is in erected position. Here, if you see, this is the position. Here, this is your glenoid and this is your head of the humerus directing superiorly. So there is no adduction possible, no any movement possible. So this is the classical presentation of patient who is having inferior shoulder dislocation. So what is inferior shoulder dislocation? The head of humerus is lying inferior to the glenoid cavity. So if you see, this is your glenoid cavity and this is not head of the humerus. So not, what happens is inferior shoulder dislocation. This is your glenoid cavity and the head of the shoulder is down and humerus is directly upward. So this is the presentation of the patient who has shoulder dislocation inferiorly. So this is otherwise termed as luxato erecta. So how will you define? So it is inferior dislocation of the shoulder or glenohumeral joint, and the head of the humerus is trapped underneath the cricoid and glenoid. So this is how the presentation is. If you see here, this is your head of the humerus, which is directing inferiorly below the glenoid. So this is the important structures around the shoulder. We have done already with it. Anteriorly, we have subscapularis. Superiorly, we have supraspinatus. Then the deltoid muscles coming here. And we have axillary nerve coming in here like this and supplying the lateral aspect of the proximal humerus. So this is how the neural bundle, the brachial plexus coming out here, and the branch of axillary nerve, it comes out here. This axillary nerve muscular supply to deltoid and teres minor, and it supplies sensory supply to the lateral aspect of the proximal humerus. So this all you need to know when you are dealing with any type of shoulder dislocation. So uh, this is just revision of the previous classes. So it's nothing new. So we'll move on to the next slide now. If you see here, again, this is repetition of the previous slide. What are the stabilizers of the shoulder joint? As I told you before, we have static stabilizer in the form of ligaments and labrum. We have dynamic stabilizers out of the rotator cuff and long head of the biceps is very important. And the support is by labral cartilage, negative intra-articular pressure, and retroversion of the joint. So these are the various factors which hold the shoulder joint in place. So if you see here, this is the glenoid labrum, which is increasing the depth and the curvature of the glenoid, increasing the 50% increase in contact area. Then we have the two ligaments starting from the coracoid. So we have coracoacromial ligament and coracohumeral ligament. These give support to the shoulder joint and shoulder won't move outside. Then there is condensation of the capsule in the form of superior glenohumeral ligament, middle glenohumeral ligament, inferior glenohumeral ligament, and a ligament anteriorly in the form of spiral or oblique glenohumeral ligament. So these are the dynamic stabilizers, static stabilizers. So they won't don't change their length, but they give support. Then we have two dynamic stabilizer. One is a rotator cuff. So in previously also I have drawn, this is a shoulder joint. Anteriorly we have subscapularis, superiorly we have supraspinatus, infraspinatus, and teres minor here. So they all push the head inside the shoulder joint. Any damage to the rotator cuff result in instability of the shoulder joint. And the last is your glenoid. So this is your glenoid. Glenoid also increases the depth of the shoulder joint and increase the contact area and stability. So with this anatomy in the mind, we'll move on to the pathophysiology. So here it is very high energy injury. So there is a hyperabduction, as if the patient is falling from the height holding it. So what is happening here is shoulder is getting fulcred out over the scapula. So this is the mechanism of injury when your patient is having the shoulder dislocation, dislocating inferiorly. So when it dislocate inferiorly, it damages the capsule and labrum, and it tears all the static and dynamic ligaments or structures which are holding it. So there is a history of injury. Patient will have severe pain and abduction deformity. So what is this attitude is very important. The position of the limb is very important. As I told you before, here it will go into abduction like this. So it's a overhead abduction. And so there is no adduction is possible. So adduction is gone. Then it's very fixed. There is no any movement allowed. So abduction deformity is the presentation of patient who has shoulder dislocation inferiorly. So these are the neurovascular structures which are very close to the inferior margins of the glenoid. So we have cephalic vein and the axillary artery here, and we have the brachial plexus going all the way down. So we have these injuries are very common when compared to anterior and posterior shoulder dislocation. Inferior shoulder dislocation have more chance of developing injuries to the brachial plexus, injury to the axillary artery, and there is associated proximal humerus fracture. As I told before, there is dynamic and static stabilizers get damaged due to shoulder dislocation. So we have brachial plexus injury, axillary artery injury, proximal humerus fracture, rotator cuff injury, and anterior capsule and labral injury in patients who have inferior shoulder dislocation. So how will you diagnose it? So it's a diagnosis is most of the time clinical diagnosis, and when you need to take the X-ray to look for the direction of the dislocation. So when you take the X-ray, we have in the head of the humerus is lying inferior to glenoid. If you see here, this is the glenoid cavity. Head of the humerus is lying inferior to the glenoid cavity. So and the head, direction of the humerus is directing upwards. So this is how the X-ray appears in inferior shoulder dislocation. So head of the humerus is lying inferior to the glenoid cavity, and this is the attitude you will have in patient who have inferior shoulder dislocation. We do CT scan, not very common, but if you suspect any subtle fractures, and we often do MRI to rule out any rotator cuff injury. This is after the reduction of the shoulder. So main is first we need to reduce the shoulder. After that, to assist the further injuries, we do MRI to rotator cuff ligament and the capsules, all these structures damaged or intact. Then what is the treatment? So there are two ways of treating inferior shoulder dislocation. One is traction and counter traction method, where somebody will give counter traction this way, and the traction is given in the direction of the deformity. So this will pull the head of the humerus upwards and causes reduction of the shoulder joint. The other thing is we need to convert the shoulder joint from posterior inferior dislocation to anterior dislocation. So sorry, this is not superior dislocation, it is inferior dislocation. We are converting the inferior dislocation to anterior dislocation. So we are sliding the shoulder joint from here to here, bringing it inferior to subcoracoid. And once it is become anterior dislocation, you can reduce with the same method we do for anterior dislocation. So what are the methods we do for anterior dislocation? One is the Hippocrates method, which is outdated now. The other is the traction counter traction method. Counter traction. The other is Stimson's gravity method. The last one is Coker's method. Coker's method, as I told, T India. This is very important to remember. These all are the methods of reducing anterior dislocation, not posterior dislocation. So traction external rotation, abduction, internal rotation. This is how we reduce the patient who has inferior shoulder dislocation. One is converting inferior dislocation to anterior dislocation, then reducing it as an anterior dislocation. Second is just giving traction in line with the deformity to bring the shoulder head of the humerus into the glenoid. And if patient is having other associated injury, we do MRI after the shoulder dislocation. And if patient has rotator cuff injury, you need to treat rotator cuff injury. If patient has fracture, you need to fix the fracture accordingly. So this is all about inferior dislocation. Inferior dislocation, once or twice it was asked as a short note in your final exam, and 2-3 questions definitely going to come in your PG entrance also. It's not very common, but there is an entity inferior shoulder dislocation. So uh, with this, I complete all the all the things in relation with dislocation, anterior, posterior, inferior shoulder dislocation, along with the anatomy and the structure which are responsible for giving stability to the shoulder joint.